So maybe I'll speak with you personally,
Yeah,
and we can find a way to accommodate them in those sessions.
Sure. Yeah, I think once we exhaust it,
we can give few slots to South.
Yeah.
There are much more than in North. Also, we have left only one. That Guwahati is left. Otherwise, we have gone all around. So I think.
Those who have been requesting for quite some time, I think it's time that we probably would want to listen to them.
Yeah, I think it may be a good idea to come, because there are more MCH centers in South compared to other parts of the country.
Yeah.
So I think, and as far as I know, there are no more left. The ones which are left they've just started a course, so they don't really have third-year residents or things. They're just people just on the verge of joining.
What about Rishikesh? Do they have surgical oncology?
They don't have I don't think they have an MCH program.
They have head and neck oncology, head and neck surgery program.
Yeah, so
we have got a couple of students from Rishikesh here as an observer.
But I don't know about an MCH program. And see, Jodhpur we have already taken, and there is one which is starting in Dehradun, and which Dr. Saini is starting, and then there is one which in Jaipur, maybe they have a first-year resident who just started a year back in Jaipur also, in SMS. But apart from that, I think we've taken all.
Maybe later on we might have to go through the same centers once again, rotate.
Yeah, and the other thing is we are running out of examiners, and I think we have covered several topics now. So you need to rethink how to carry it forward or how to do this more. I mean,
we might have to slow down later on. Maybe it should be once a month. I think we have done justice for the third-year students who are taking the exams, but from now on, maybe we might have to slow down so that we don't burn ourselves also.
Yeah.
September we are at IASO. I think September we can skip. After South, we can skip the second half of the September. Then we can go for the October again, because IASO meeting is there. So
no, it's in October, so we probably would not do anything in October.
So we will have an opportunity to rethink about this, Arnab, and maybe we will speak separately at some point of time regarding this.
Correct. So, sir, it's 7:01. Dr. Altaf Seth sir is just joining in, sir. He joined and then got disconnected probably.
Is it traveling?
If we have everyone's permission, shall I start the webinar, sir?
Yeah, please.
Yeah, I think we should.
Thank you so much, sir. We are live now, sir. Thank you. Good evening, everyone. Welcome to the 21st chapter of the Masterclass series brought to you by IASO Academics. Today's topic is esophageal cancer. I invite the IASO President, Dr. Anu Gupta, to kindly open the session.
Thank you, Sajan. A very good evening and welcome to today's 21st PG Masterclass. So on behalf of IASO, we would like to thank the Academic Council for running this course smoothly and seamlessly for so many months. It's amazing when we started, and it's already 21st webinar that we are doing now, PG Masterclass. And every time we had been having very good attendance. It has been star attraction, all the faculties, the trainees have done well in presentation. I'm sure we're going to have another wonderful show today. Today, the topic is esophagus, and we have wonderful faculties again. Our attraction, obviously, today is Dr. Pramesh from CS Pramesh, the director of Tata Memorial Hospital, Mumbai, who's going to give an expert talk at the end of the presentation, once the candidate has finished with his presentation, with his examination. And then we have Dr. Altaf Syed from Bangalore, Dr. Jagjit Pandey from Patna, and his student, Dr. Satish Kumar, is going to present today. He's the examinee, so all the best to him. And I would like to thank once again all the members of Academic Council, the leader obviously being Dr. T. Subramanya Rao. He's been the convener, ably assisted by Dr. Sajan Shukla. And like I said, it has been running so seamlessly. And Dr. Arun Chaturvedi, Dr. Kiran Kothari, Dr. Sarangi, and Dr. Rajaraman, all the 4 past presidents have been the advisors for us. So, they had been doing a wonderful job, and Dr. Sarang is the one who has organized today's PG Masterclass. So special thanks to him. And those who are attending the meeting today, once again, a reminder, please become members because there's so much to offer from IASO. So just log into the website, iasoindia.in, and become member. It's going to be online, so it's not much of hassle. You just need 2 recommendations. And without wasting any more time, I'd request Sarjan to take the meeting forward. All the best. Thank you.
Thank you, sir. I invite Dr. Sarangi, sir, to please introduce our examiners and the examinee today.
Good evening. It's a pleasure to introduce the stars of surgical oncology. And Dr. Pramesh, I don't think he requires any introduction to the surgical oncology fraternity. He has been conducted, he is the master of National Cancer Breed. Most of the centers are member of National Cancer Breed. And a few things which I came to know from his resume, which have been given to me. He passed out from Coimbatore Medical College, 1993. And then KEM Hospital, Bombay. And he actually took forward the thoracic oncology in this country. Great strides, along with the National Cancer Breed. So his credential, his academic background is unparalleled, unchallenged. And we are very fortunate to have him today as an examiner, and we're going to listen to him at the end. Dr. Saeed is an alumni of Kidwai Memorial Institute of Oncology. He did his undergraduate from Bangalore, undergraduate, postgraduate, both from Bangalore. And he's a faculty for last 20 years. And I'm told that he's an excellent surgeon. Whether he has joined? Has he joined? No. Dr. Saeed has joined? I don't see.
He joined and again got disconnected, sir. I think he is having a network issue.
I think once he joined, then we'll interact. Jagjit Pandey, the young budding star of AIMS Patna. He did his oncology from GCRI Ahmedabad, and then he joined various institutes like Calcutta Chittaranjan Cancer Institute, and working in Patna, AIMS Patna. And his major interests are upper GI cancer and gynecological cancer. He has done quite a number of high-tech. He is a man to be watched and followed so far as the high-tech procedures in Northern India is concerned. And we are fortunate to have him here. And he has a student, Dr. Satish Kumar. He's a third year MCH, and he's going to present us with a case of carcinoma esophagus tumor.
Sir, pardon me, sir. Sir, Satish is second year student.
Okay, second year. Fine.
Yeah, just one in the second year. Yes. Sir.
And without much wastage of time, I invite the examinee to present his case. Thank you. Over to Srijan.
Thank you, sir.
Thank you, sir. Just a couple of instructions for the webinar for our candidate. If you don't know some answer, there's no harm in mentioning it because it saves time and maintains the flow of the webinar. And it's up to you to catch all the hints that our examiners will be giving. For our dear examiners, this is an online live webinar with future attendees as well who will view it on YouTube. So if there's some question which remains unanswered or has been incorrectly answered, unlike a real exam, we please request you to give the expected answer. The case discussion is allotted 60 minutes. I'll be reminding the examiners at 30 minutes and at the conclusion of case discussion. I request Dr. Pramesh sir now to take the proceedings forward. Thank you.
Thank you. Thank you very much, Srijan. And I'll thank IASO for this opportunity to be part of this excellent series, which will go a long way in improving the overall surgical oncology education and training in the country. In the interest of time, I'll request Dr. Satish Kumar to make his initial case presentation, and then we'll take the discussion forward. And I'll request my co-examiners to chip in at any point they feel it's appropriate. Please go ahead, Dr. Satish.
Thank you, sir. So is my screen visible?
Yes, it is.
Good evening to all. Myself, Dr. Satish. I'm a resident from AIMS Patna.
Satish, can you put it on screen show? Yeah.
Okay, right now, sir?
Yeah, we can see it on full slide, but I don't think you're on the first slide. Are you on? Yeah, great. Please go ahead.
Patient details. He's a 16-year-old gentleman, former by occupation, and from Chapra, Bihar. He presented to OPD with chief complaints of difficulty in swallowing for the past 6 months and a cough for the past 4 months. Patient was apparently normal 6 months before. Then he developed difficulty in swallowing, which was insidious in onset, progressive in nature, initially only for solids. Initially, he was able to take solids with difficulty, later acquired liquids along with solids to consume solids. There's no history of associated pain, no history of regurgitation. He typically gives a history of sticking of sensation of food sticking to mid-chest, which gets relieved on taking liquids. The history of a cough present for the past 4 months, which is intermittent, non-progressive, non-productive, not associated with pain, hemoptysis, or breathlessness, which was relieved on taking cough syrups. No history of painful swallowing, excessive salivation, ulcers in the oral cavity, no history of neck swelling or neck pain. There's no history of halitosis, no history of accidental corrosive intake or chronic NSAID use. There's no history of coughing or choking immediately after food intake. And there is no history of long-standing heartburn or regurgitation. There's no history of vomiting, abdominal pain, abdominal distension. There's no hematomesis or melena. There's no history of chest pain, breathlessness, fever, or hemoptysis. Patient doesn't give history of any voice change or recurrent respiratory tract infections. And there is also there is no history of loss of weight or loss of appetite. There's no history of jaundice, bone pain, headache, seizure episodes. There's no history of any upper GI or in the past. Past history, he is a known diabetic on regular medication for the past 14 years under control. There's no history of hypertension, bronchial asthma, tuberculosis, COPD, or CAD. The onset of symptoms, patient went to the nearby hospital where the complete workup was done, and he was diagnosed as a case of cancer esophagus and started on chemotherapy and radiotherapy according to the patient's history. According to the history of the patient, he received...
Satish, can I interrupt you at this point?
Sure, sir.
So I do understand that you got the patient after he was already started on treatment, but based on the history of present illness, what would your approach be? Forget about what's happened to the patient. If the patient were to come to you, what would your approach be?
The patient came with the complaint of swallowing the cough. Apart from that, these two findings makes me think of upper aerodigestive tract pathology, sir. So because of difficulty in swallowing, I would like to ask history regarding any oral cavity lesions or oropharyngeal lesions. Then I'll move on to the esophageal lesions, sir. At the same time, I'll ask history regarding any kind of respiratory tract infections. Based on the history, there's no history of painful swallowing or excessive salivation, which rules out the oral cavity pathology, sir. And there's no history of neck pain or neck swelling, which rules out our oropharyngeal pathology. And there's no history of any chest pain, breathlessness, fever, or hemoptysis, which in a broad sense rules some kind of lung pathology, sir. With the history of difficulty in swallowing, I might narrow it with the diagnosis of any esophageal pathology. Dysphagia, which is progressive and sudden in onset, I'll think of some esophageal pathology in my history presentation.
So how would you approach this patient? So this patient has come to you with this history. I know from a theoretical point of view, you need to rule out oral, all of that. But with this classic history of difficulty in swallowing, a sensation of food sticking in the middle of the chest,
Yes, sir.
you're probably, I mean, forget that this is an exam. You're probably right in assuming that this is a pathology in the esophagus. So how would you approach this question?
So based on the history, considering age of the patient, I would like to do it in a malignant dysphagia, sir, based on the history alone. So I would like to do an examination for this patient for further evaluation, sir.
So can you, without going into the rest of it, can you describe whether there was anything remarkable on examination?
No, sir. The whole examination of the patient was unremarkable, sir.
Right. So you've done that. So what's your next step now?
Go to the examination.
So with the history of examination was normal, sir. Oral cavity, neck, and chest examination, abdominal exam, all within normal limits, sir.
Go to the slide. Go to
Yeah.
the slide.
I'm really sorry to interrupt, Dr. Satish. If you stop your video, I think your audio and both screen might get a little better. I understand you are having a network issue there.
Yes. So, sir, you want me to stop my video?
Just the video, yeah.
Right now, sir?
Yeah, please go ahead.
Yes. So examination of oral cavity, patient got adequate mouth opening and a normal oral hygiene. Next examination is normal. Visible right now, sir?
Yeah, you are audible. Go ahead.
I can't change my screen, sir.
So practically there is nothing on clinical examination that's remarkable, right?
Yes, sir. Yes, sir.
So yeah, sure. So let's forget the slides. How would you want to proceed with this?
Patient, with this history, I will think of an malignant dysphagia, probably a carcinoma esophagus, sir. So I would like to do an apart from routine blood investigations, I would like to do an upper GI endoscopy for this patient first to proceed further, sir.
Okay. Do you want to show the upper GI endoscopy findings?
Sure, sir.
While we are waiting for the slide to move, would you want to do a barium swallow in this patient?
Sir, like with the current barium swallow, not to get any kind of further information apart from upper GI endoscopy, sir. So I don't prefer to do a barium swallow in this patient. I would like to go for upper GI endoscopy, sir.
Sure, that's a great answer, because something that was done routinely a couple of decades back is now practically redundant, because regardless of whether a barium swallow shows an abnormality or not, you need to go ahead with an upper GI endoscopy anyway, and therefore the barium swallow really doesn't add much to the workup. Please go ahead. Show us the upper GI endoscopy finding.
So can you just tell me what is the screen right now? You're able to see it, sir.
Oral cavity, neck examination.
I'm not able to change the screen, sir.
Satish, I'll just stop your screen sharing. Could you start it again?
Is it visible right now, sir?
Yeah.
Yeah.
Able to move my screen, sir. I'm not able to change my slides.
Go down. Go down.
No, sir. I'm able to do it.
So are you able to, if you stop sharing, are you able to see your screen?
Hi, is it okay?
Yeah,
right now,
now we can see your screen changing.
yes, sure, sir. So, are you able to see the upper GI endoscopy for this patient?
Yes, we can.
This is a pre-CTRT of the patient report, sir, before starting chemotherapy and radiotherapy for the patient. And unfortunately, we are not able to retrieve all kind of information from the patient documents. So this is the provided information. Based on the report, an ulcerative growth present at the 35 centimeter from incisors extending up to the cardia. Stomach, fundus, body, and pylorus were normal. Duodenum were normal, sir. This is a report provided to us.
So do you really want any more additional information that's relevant to your case here?
Yes, sir. Yes, sir.
What would that be?
Additional information like the distal extent of the lesion. They have mentioned only till cardiac was there. So whether it involving the stomach or not, I just want to know that lesion. And I just want to know what are the other in the esophageal mucosa. Is there any other mucosal lesions present in the proximal part of esophagus? There's no comment on that, sir. And whether biopsy has been taken or not, there's no comment on it, sir.
Okay. I'm assuming that if they've started some treatment, there would be a biopsy, right? Or do you not have information on that?
Also do a biopsy report, sir.
Biopsy report.
Biopsy turned out to be a moderately differentiated adenocarcinoma.
Okay.
Yes, sir. So this was the first upper GI report.
So let's stop that for now. Let's stick to the first upper GI scopy report, pre-treatment. You got this patient whose tumor is starting at 35 centimeters, going right up to the cardia. They have mentioned that the stomach fundus is normal. So let's assume that the report is correct and the biopsy is showing moderately differentiated adenocarcinoma. What would you want to do?
Yeah. So like based on this report, I can assume that this patient comes under category of G junction tumor with a lower esophageal involvement. So in the next step, after the biopsy is taken, I assume that patient does not have any obstruction because fundus and duodenum are visible through the endoscopy report. And I love to do further investigate this patient by doing an contrast enhanced CT of thorax esophagus with neck cuts.
Okay. Do you have that report?
Yes, sir. So it is a CCT abdomen and a chest report, which is done previous to CTRT. Diffuse thickening of distal esophagus with a heterogeneous enhancement extending into the G junction and cardiac stomach, maximum thickness of 8 mm. There was no comment on what is the distance of the length of the involvement. Thick esophagus, aorta, and no significant lymph node enlargement. No further details available in the report.
So you mentioned something about the length. How is that important?
So like length gives an idea like what kind of it is going to it increases it changes the prognosis of the patient, sir, and helps us to find in which level of esophagus we're dealing with, and it also decides a nodal involvement of the patient, sir.
Yeah, so I think they've mentioned about the nodal involvement.
Yes, there's no signal lymph node enlargement.
So is there strong data to suggest that the length of the tumor influences prognosis or changes your treatment in any way? Besides, of course, your margins. It would certainly impact on your margins, but does the length really impact the prognosis?
Not always, sir.
So actually not, because it used to be one of the criteria for staging esophageal cancer in the late 90s. In 1990, the AJCC did involve the length of the esophagus as one of the staging criteria because it impacted on prognosis. But with the current investigations that we have with the level of T involvement and N involvement, these are found to be much more stronger predictors or prognostic factors rather than the actual length itself. So the question of length only comes in when it comes to your margins that you need to address at the time of surgery.
Yes.
So are you happy with this statement that focal abutment of thickened esophagus with the aorta?
So I just want to know what is the degree of involvement, sir, because that gives an idea whether the esophagus, whether the aorta is involved or not, sir.
Very good, very good. So what's the degree of involvement that you are worried about?
Say if it is less than 45 degree the involvement of iota is unlikely, sir. If it is a 45 to 90 degree, it's indeterminate. If it is more than 90 degree, the risk of iota involvement is high, sir.
Excellent, excellent. So you've got all of this. Let's assume for the fact of, for the sake of argument, that the focal abutment means it is less than 45 degrees and not more, I mean, it's not more than 45 degrees. At this point, how would you want to approach this patient if this patient had come to you directly?
So considering this is less than 45 degree, this is not an involvement of iota. So based on the report, it looks like an T3N0 disease, sir. And there is no comment on metastatic workup in the CT scan, sir. So whether what are the metastatic organs are involved or not, so there's no comment on it, sir. I just want to do further workups to know the metastatic workup of this patient, sir.
And what would that be?
If the proper report of this patient shows no involvement of any other liver, lung, or any other metastasis, we'd like to do an PET CT scan for this patient, sir.
Right. And what's the data supporting that?
By doing a PET CT scan, we can change 20% of change in the plan of management will occur in the patient, sir.
By finding metastasis outside the field of a routine CT thorax and upper abdomen, right?
Yes, sir.
Yeah, please go ahead with the PET CT finding if it was done prior to CTRT.
So we don't have an prior CTRT PET CT finding, sir.
Okay.
But
yes. It was not done prior to the treatment.
Sure. So let's assume for the sake of argument again that the PET CT is showing no other metastasis other than what the CECT is showing here, the extent of disease.
Yes.
And sorry, I do realize I'm hogging the conversation here. So please, Dr. Pandey and Dr. Altaf, please feel free to chip in at any point. Yeah, go ahead, Satish.
Yes, sir. So this is a post CTRT of this patient.
No. So I want you to go back to that previous slide where you showed the CECT thorax pre-CTRT and assume that this patient has come to you at this point and the post and the PET CT is not showing any other site of metastasis. What would you want to do?
So, sir, Satish wants to know what any additional workup you want to do, or how will you proceed further with your upper GI endoscopy, CT scan, and PET CT?
Yes, sir. So based on the investigation provided, patient seems to be an T3N0 disease. So further, I just want to evaluate the patient performance status and the general condition of the patient, sir. Then my plan of action will decide accordingly, sir.
You already know the general condition and the performance status of the patient, right? You've examined the patient at that point. So please describe that and go ahead with what you want to suggest.
Yes, sir. Patient performance status, one according to ECOG performance status, and the patient doesn't have any kind of edema or any kind of nutritional impairment on general examinations, and rest of the clinical examination, CVS, RS, and the abdomen and neck examination were normal levels, sir. I assume this patient have a very good performance score according to ECOG. So based on the provided information, assuming this is an GE junction tumor, preferably an severe type 1 because of proximal 5 centimeter of esophagus is involved, I would like to do I will go for a neoadjuvant therapy in this patient, sir.
Okay. And what would the choice of neoadjuvant therapy be?
Yes, sir.
What would your choice of neoadjuvant therapy be?
Sir, actually, there's a controversy when we are dealing with the GE junction tumor, sir. We have multiple options for GE junction tumors. There are a few studies which favors a neoadjuvant chemoradiotherapy. There are a few studies which goes in favor of neoadjuvant chemotherapy. Even the treatment is geographically as well, sir. If you go for Japanese side, they have a different set of management. If you go for Western side, they have a different set of management, sir. So
what is routinely followed in your institute?
Sir, considering this and severe type 1, the patient will be managed accordingly as esophageal malignancy, sir.
Yeah, what is the routine chemotherapy which you follow in your institute?
We give a neoadjuvant CTRT for the patient, sir, backlick upper region.
Okay.
But in this case, this is an adenocarcinoma, sir. So I will to give an neoadjuvant chemotherapy for this patient.
What will you prefer?
So considering this is a GE junction tumor, I prefer to give an neoadjuvant chemotherapy in this case, sir.
What are the various regimens?
So for CTRT, we have a cross trial.
Yes.
With weekly Paclitaxel carbo along with 50 grays of radiotherapy to the area. And there's another protocol of MAGIC trial, which justifies a neoadjuvant perioperative chemotherapy.
Are you sure about the 50 gray radiation, Satish, in the cross protocol?
Sorry, sir. It is 41.4 grays, sir.
Yeah,
Yes,
so the 50.4 is actually the NCCN protocol where they consider that even if the patient doesn't end up with surgery, at least we've given a definitive chemoradiation dose. So the cross protocol is actually 41.4 grays of radiation. Yeah, go ahead.
Yes.
Satish, if you prefer to give neoadjuvant CTRT, what are the fields of radiation you prefer to go for? Whether it's a 2-field or 3 or 4-field radiation, what will you prefer?
So considering this is a GE junction tumor, I prefer to go for an 2 fields. And right now, the radiotherapy fields are configured according to the disease. Like we have something called GTV, where the gross tumor volume along with the clinical tumor volume along with the planned tumor volume, we have a margin, and this margin corresponds to the nodal status as well, sir. We also go the gross node involved node, and from that we go 1 to 1.5 centimeter to involve the node, sir. Considering G junction tumor as a very less likely metastasis to a cervical region, I'll go for a 2-field radiation in this patient, sir.
Yeah, you can go ahead.
Actually, what happens whenever there is what is 2-field in radiation? It's an AP and PA view. So whenever you are giving radiation in a palliative setting, only then you prefer to give in 2 fields. Otherwise, it's generally for a neoadjuvant or definitive purpose, you prefer to give 3 or 4 fields radiation. Okay, so apart from AP and PA view, you give lateral fields also. Yeah. Go
Okay.
ahead. So you are planning neoadjuvant CTRT in this patient?
Yes, sir. So,
okay, why don't you describe the chemoradiation and the post-chemoradiation findings?
Yes, sir.
Did the patient tolerate?
This is a post-TRT upper G endoscopy report of the patient, sir. After the CTRT, esophagus were normal mucosa, lower end of the esophagus shows narrowing at G junction. G junction is present at 40 centimeter. Small area of thickening is seen without erythema or ulcer. On the gastric side of G junction, that is in cardia, mucosa is thickened with mild hyperemia. And fundus, body, and antrum appears normal. Duodenum appears normal. This is a post CTRT of the endoscopy finding of the post CTRT.
So what do you want to do next?
Sir, I would like to do an CCT of this patient, sir. CCT abdomen and
CT?
CCT abdomen and this is a CCT thorax abdomen of the patient with neck cuts, irregular, heterogeneous, enhancing, circumferential, mural thickening is in the distal esophagus, G junction, and cardia. The maximum length of 3.5 centimeter and a thickness of 1.3 centimeter. Mild luminal narrowing is present. Department with the descending aorta is present with maintained fat hilum. Department is less than 45 degrees. Above the left crux of diaphragm with the loss of fat plane. No obvious mediastinal, celiac, or cervical nodes. And the rest of the findings were normal.
So how would you proceed?
So like based on the finding, there's kind of persistent disease even after chemotherapy in this patient, sir. So as we don't have a PET-CT for this patient previously, I would like to do a PET-CT for this patient. So to know the distant metastatic disease.
Was that done?
Yes, it is done, sir.
Yeah, please show us the findings.
Whole body PET-CT, faint FDG aware, SU of 1.9, wall thickening of 6 mm is seen in the distal esophagus and adjoining GE junction. Fat plane with the left crux of diaphragm is poorly maintained. No mediastinal abdominal nodes identified. No evidence of distant.
Tish, what additional advantage of getting PET-CT done in post-CTRT patients if PET-CT was done pre-CTRT also, apart from your distant metastasis?
So if it is one pre-therapy, it helps us to.
Satish, you are not audible. Yeah. What is the advantage?
Am I audible right now?
Yeah,
sir?
yeah.
It helps to find response of the treatment.
What response you expect?
So we see if you have a previous PET-CT report, we compare the SUV of the patient, whether if it is less than 35% decrease, there is a good response. This is not less more than, it's not more than 35%. They are poor responders to the previous neoadjuvant therapy, sir.
Okay. Does this response has any effect on survival benefit?
Yes, it has an effect on survival of the patients, sir, because poor response patients, you can change the management plan and
You're not audible.
am I audible right now, sir?
Not audible.
Yeah. Yes, Satish.
Yes, sir. So based on the response, if they're good responders, we can continue that in neoadjuvant therapy. If the response is poor, we can switch over to new some other regime of chemotherapy, or we can take it for surgery, sir. It's how it can change our management plan, sir.
What do you do next?
Sir, sir.
Yeah. What do you do next after this? After PET-CT?
So considering a good response, looking at what we have from upper GI scopy, contrast enhanced CT scan and PET-CT. Now previous PET-CT, we don't have the report. With this PET-CT and all those investigations, what is your finding? Whether the patient is a responder or non-responder?
He's a responder, sir. He's a responder.
So the next question comes from Altaf sir, how will you proceed?
Based on this finding, I would like to take this patient for surgery after adequate pre-op preparation of this patient, sir.
How do you prepare this patient for surgery?
So like if the patient is a smoker or alcoholic, I'll ask them to cessation of smoking and alcohol at least 4 weeks prior to surgical procedure. And I'll try to improve the nutrition of the patient. If the patient is not able to take orally, I will try to encourage, try to get access to the enteral feeding either through rails tube or surgically. And third, I would like to improve the pulmonary function of the patient, sir, by encouraging him to do an chest physiotherapy in the form of spirometry.
Satish, focus on your patient only. Now, with your findings, you have suggested that there is only mild numeral narrowing post CTRT. So,
Yes,
what is the purpose of putting the patient like rice tube or any other nutrition? Is oral nutrition, enteral nutrition?
No, sir. No, sir. No, sir. In this patient, we don't need it, sir. In this patient, we don't need it because patient is there's no obstruction and there's no symptoms of obstruction for the patient from history as well, sir. So patient does not need any kind of rice tube insertion and any kind of surgical methodology, sir.
Okay. What other, like you are suggesting pulmonary function test. What do you expect from pulmonary function test in this patient? And what is your how will you optimize the patient?
I would like to do an pulmonary function test, PFT, in this patient, sir. So in we like to see an what is a FEV, forced expiratory volume, what is a, and FVC, forced vital capacity, and the ratio of both, sir.
Okay. Apart from pulmonary function test, what additional, any other?
Any other investigations you will do other than PFT, which can help you to further plan?
So considering a G junction tumor, I would like to do an staging a laparoscopy as well in this patient, sir.
Any other investigations other than PFT, what other tests you will do to see that the patient is fit for surgery?
I like to do a 2D echo for this patient, sir.
Yes. What else?
So considering this G junction tumor, bronchoscopy is a patient, sir.
You're not audible.
That's it, sir. Like, bronchoscope not necessary in our case, sir, considering it's in a lower.
Yes.
Satish, I think if your slides are done, you can stop screen sharing. It will help you.
Yes, sir. Yes, sir. Am I visible right now, sir?
Yes.
Yes, sir. So I will optimize the patient nutritionally and pulmonary functionally, and I'll take this patient for surgery, sir.
Before taking up to surgery, what are the things you will try to discuss with the patient?
So obviously, management will be a multidisciplinary approach for this patient, sir. That starts from the point of view. So considering if everything was done, I will explain the procedures of the patient. What are the options he has got surgically, and what are the benefits and demerits of each and every surgical procedure, and what kind of post-surgical care he needs, and what is the need for any kind of adjuvant therapy, and patient will be counseled regarding the post therapy follow-up and surveillance.
So just pretend that I am the patient in front of you and explain this to me.
So considering premise as my patient, आपको तो पता है अभी lower esophagus में
you can continue to speak in English. I just want you to cover what points you are going to cover.
Yeah, sure, sir. So with the provided investigations and results, we confirm diagnosed the case of an lower esophageal malignancy, and which has responded in the previous treatment, but still the disease is persistent. So in order to eliminate the disease, we have to go for a surgical procedure in you. During the surgical procedures, as I mentioned previously, you need to stop your smoking or alcohol if you're consuming previously, and you have to continue the spirometry and all kind of chest physiotherapy exercise I have mentioned in the OPD basis, and you have to have a nutrition which is rich in protein and diet. So all these things have to be taken care. When coming to the surgery part, we have multiple surgical options for your cancer. Either we can operate through an
Doctor, I don't understand these multiple surgical options. Please tell me what surgery you will do, and I will go by what you suggest.
Yes.
What is that you have in your mind to plan for this particular patient? What is that you will keep in your mind and tell, if this is what I'm going to do this for you? What is that you'll have? You have to explain regarding that, and what are the pros and cons of that particular procedure, plus what are the complications you are anticipating by doing this procedure.
Yes, sir.
You have to be very clear when you're telling all this.
And assume that you have all the facilities at your hand.
Yes.
Finance is not a constraint, resources not a constraint, expertise is not a constraint. What option will you suggest?
From the we can go for either a minimally invasive procedure in you, or can go for an open approach. So in our institute, based on the experience, we are very comfortable with doing open approach for you. It's our institution preference. So even though our literature says that the minimal invasive approach has an advantage over it, but our institute, we are doing more of open cases. We'll try to do an open procedure in you. So in open procedure, we have an either we will open the abdomen and we'll proceed further without any incision in the chest, or we have an option of doing chest as well. Now comes the question, which I prefer in your case. So in your case, without any previous reports or without any proper previous reports, I have no idea how much of lymphadenopathy and the extent of disease and extent of distant metastasis previously. So by doing an transhiatal approach, which I mentioned as an abdominal approach, so there is a chance that we might miss some of the disease intrathoracically. So in your approach, I would like to do a transthoracic, in which I will open the chest and do a dissection, and we also open the abdomen and we'll do a dissection there, and finally we'll make an surgery in the neck. So now comes the question, what kind of surgery I will do in you? So in your procedure, I will take the complete esophagus. It starts from the neck till the abdomen, and after removing it, we make a tube of your stomach, which will be pulled up till your neck, where it will be anastomosis. So why I want to prefer this is, in case post-operatively, if there is any kind of complications, we are in a better way to manage it if it is made in the cervix, in the neck, rather than in the thorax. So this is the reason we just want to do a transthoracic. In technical terms, we call it as a make-your-own procedure.
So would your decision have changed if you had a pre-operative, pre-treatment PET CT which showed no metastasis?
Yes, sir. In this patient, considering lower GA2, we can go for an IVR as well, sir. But from patient perspective and from the institution guidelines, the managing intrathoracic leak is quite complicated for the patients. So
I completely agree with you on that. It's institutional preference, and we would also probably do the same. But your logic initially that the reason you preferred a transthoracic was because you didn't know the pre-treatment metastatic status of the patient is a little flawed. Because with the current generation CT scans that we have, the likelihood of your missing an intrathoracic metastasis and the added advantage of getting a PET CT within the thorax is extremely low. So preference is fine. That's absolutely something no one would argue with. But the logic that metastasis will not be picked up if you don't enter the thorax is not correct.
And one more option in this patient is radiotherapy as well, sir. So that also have an extensive fibrosis in that region. So while going for a transhiatal approach, the risk of damaging the adjacent structures is there, sir.
Are there any studies to support that? That complications are higher if you do a transhiatal after neoadjuvant chemoradiation?
Sorry, sir, I don't know.
There are not. So it can be institutional preference, individual surgical preference as well. There's very little to support the other reasons that you said.
How is the recovery in a patient when you're taking transthoracic, and how is the recovery of a patient when you're doing THE?
Transthoracic procedure got a higher pulmonary complication rates when comparing to a transhiatal approach, and the early postoperative mortality is also higher according to the previous studies. But overall survival and disease-free survival was not that much change when comparing to both approaches.
Satish, what sir wants to ask, what is the immediate complications you expect in both?
Both
Transthoracic and transhiatal. Not.
So you have to tell to the patient.
Long term.
You have to tell to the patient when you go transthoracic approach, what is the complication you will anticipate. You have to tell him in advance, and what are the complications you see when you're going for transhiatal.
The risk of having a major bleed is high when you go for transthoracic approach, and risk of a vital organ injury is also there, sir, in transthoracic approach, and the risk of recurrent laryngeal nerve is also high when you go for a transthoracic approach, where the we do a cervical port mobilization, sir.
How often you see chyle leak in your institute when you go transthoracic?
We haven't never seen it, sir.
Why I asked you this question, because you're told after radiotherapy and all these things.
Yes, so the risk of injury is comparatively higher in a transthoracic approach.
Yes, yes.
You told there is a high risk of recurrent laryngeal nerve injury in transthoracic approach than in transhiatal. What evidence do you have?
Not exactly, sir.
Okay.
Of recurrent laryngeal nerve always there when we go for cervical approach, sir. In respect of transthoracic cervical of recurrent.
Recurrent laryngeal nerve injury is more common in which type of surgery? Transhiatal or transthoracic? And what evidence do you have?
So like this raises the question that where the nerve get injured, sir. So the nerve get injured once, either in the, am I audible, sir?
Yes, 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 go ahead.
The nerve gets injured in the upper part of thoracic dissection, sir, and in the lower part of cervical dissection, sir. Where these are two areas where we encounter recurrent laryngeal nerve, sir. So while going for transthoracic approach, we got a risk in both the areas. We are doing dissection in the upper thorax as well as in the cervical region. While going for a transhiatal approach, the risk is only pertaining to the cervical region, sir. Yes, the risk is present in both cases, but quite higher in a transthoracic approaches.
How often you see recurrent laryngeal nerve injury in your institute?
No, we haven't.
Then when you do neck approach, cervical region approach, we often see the recurrent laryngeal nerve when you isolate the esophagus.
No, sir, we don't see, sir.
Can you please tell me? I can't hear.
Sir, can you just repeat the question?
I asked you, how often will you, when you are going cervical region, you will always identify the recurrent laryngeal nerve. Yes. Which is the nerve which gets injured commonly? It is the nerve which is visible or the nerve on the opposite side?
Sorry, sir, I don't know, sir. Sorry, sir, I don't know, sir.
That is, while hooking the esophagus in the cervical region, it is not the nerve which is visible. It is on the other side. When you hook it, there's a chance of getting it injured.
Yes, sir.
What precautions will you take to lessen the impact of nerve injury during your dissection?
We try to avoid any energy leakages while we are doing dissection, sir. And we go ahead with a sharp dissection, sir, rather than blunt dissection.
What other complications you expect in transhiatal esophagectomy? Common?
So the complications like anastomotic leak, anastomotic stricture is present, sir, and injury to the chyle duct is present.
Any injury to membranous trachea?
Yes, sir, but risk is there, sir.
So just suppose a patient has come, like you are operating and you land up, you are suspecting that trachea is like you have injured trachea. What, how will you guide your anesthetist, or how you will coordinate with your anesthetist regarding that when you are suspecting a tracheal injury during your surgery?
So, like
what your anesthetist will tell you?
What will be the first thing he'll tell you?
Yeah. Like there will fall in saturation and presence of pneumothorax.
What was your first answer?
There will fall in saturation with this.
The anesthetist will tell you what?
There's a fall in saturation of the patient.
Yeah. Okay.
Yes, sir. Yes, sir. Like.
Right. So you've done a transthoracic esophagectomy with the neck anastomosis. on the 4th post-operative day, this patient has an atrial fibrillation. Otherwise, clinically stable. How will you approach this patient?
So I'll suspect a leak in this patient, sir, even though the anastomosis main cervical region. There's a possibility that a leak might trickle into the mediastinum as well, sir.
Is there any other reason? That's right. You definitely need to rule out a surgical cause for the arrhythmia, but is there any other cause for this atrial fibrillation?
So in a transferring approach, we place a intracostal tube, sir. There's a chance that the intracostal tube might irritate the cardiac and might cause atrial fibrillation, sir.
Right. So it's already the 4th post-operative day, so highly likely that you have removed the intercostal drain. And anyway, if it was tickling it, it would have started right from the day of surgery rather than suddenly start on the 4th post-operative day. So it's important to rule out a surgical cause, but by far the commonest cause of an arrhythmia is just benign atrial fibrillation. It happens in up to 40% of patients after any intrathoracic surgery. So while it's important to rule out a leak, it's not the only reason. So if you have the same thing with the hemodynamic instability, what would you suspect? And how would you approach it?
I'll suspect a leak in the patient, sir. If it's a hemodynamic unstable patient, I will suspect a mediastinus in this patient, sir.
And how would you approach it?
I will open the cervical incision, sir, so that a collection with a drain out. So I try to manage the patient hemodynamically by giving fluids and all the support for the patient, sir.
Okay, you've stabilized the patient hemodynamically.
Yes, sir.
The neck is not showing anything.
So I'd like to do further investigations to confirm my diagnosis of a leak, sir. So once a patient got hemodynamically stable, I will like to do an imaging for this patient, CECT. So that might be showing a non-enhancement in the particular anastomotic site, which also confirms my diagnosis of conduit necrosis, sir.
So you're suspecting a conduit necrosis?
Sorry, anastomotic leak, sir.
Right. So what would an anastomotic leak show on a CT thorax with oral contrast?
And there'll be extravasation of contrast, sir. And there's enhancement in the region of anastomosis, sir, if the perfusion is less.
Suppose you don't have contrast going out, but there is a mediastinal collection. What's your working diagnosis?
The contrast trickling to the tract into the mediastinum, sir.
Yeah, so it's a common myth that unless you see contrast in the mediastinum, there is no leak. Most times, in fact, it's the reverse. You get a leak without contrast trickling down into the mediastinum, and even the presence of a collection should alert you to a leak. So you've seen a collection in the mediastinum,
Yes,
no
sir.
contrast within it. What would you do for this patient? Again, you have all the facilities that are required to manage this patient.
So if the patient hemodynamic is stable if the patient's hemodynamic is stable, I will try to manage this patient conservatively, sir, by putting the is already in situ, sir. So any kind of collection and administration through it, and I'll start the patient IV antibiotics, and I'll keep the patient.
You are not audible, sir.
That I will put the patient on. Am I audible right now, sir?
Yeah. Now it is audible.
I will try to manage this patient conservatively, sir, by start putting the patient on IV antibiotics, IV fluids, and nil per oral, and by external drainage, any kind of collection through the cervical wound. I will manage this patient conservatively, sir.
Most of the neck leak is managed conservatively, or you intervene.
So most are managed conservatively, sir, neck leaks.
That is an advantage of doing a trans hiatal. Doing an anastomosis in the neck is very important because of this.
Yes, sir.
But in this patient, the collection is in the mediastinum because your neck exploration showed nothing, and it's only on your contrast CT that you picked up the mediastinal collection.
Yes, sir.
So
what do you do here?
What sir wants to ask, how will you proceed when you see nothing in your neck, but you are seeing mediastinal connection on imaging? So how will you proceed?
So like in this patient after hemorrhagic endoscopic sorry, sir, I don't know.
So the important thing here is to drain the collection, right? So you would get your interventional radiologist to put in a pigtail at the site of the collection and drain it. The other option, which is a more recent option, which is not yet freely available in India, is something called the endosponge, wherein you put in a endosponge through the leak, and it slowly starts decompressing the collection, and the leak starts healing by itself. It's still not available in India, but it's used very commonly in countries like the Netherlands and other parts of Europe.
Yes.
Okay, your final histopath has come, and it shows a partial response, a YPT2N0 disease. What do you want to do?
So we started this patient on the neoadjuvant chemotherapy, sir. I would like to give a completion of
You've given neoadjuvant chemoradiation.
You have given neoadjuvant chemoradiation.
Yes, yes, sir. So if it's a T2N0 disease, in adenocarcinoma, because we have started the chemotherapy, I just like to complete chemotherapy in this patient, sir. Even to listen T2N0 patients, sir.
Any data or study to support that?
So like
in a patient who's had neoadjuvant chemoradiation and has undergone an R0 resection and your YPT2N0 disease.
Sorry, sir. In T2N0 disease, I look to surveillance.
T3N0, YPT3N0.
So in T3, T4 or N1 disease, I would like to go adjuvant chemotherapy, adjuvant therapies.
Based on any data to support that?
What will you do in T3, T4, YPT3, T4, N1 disease? What will you prefer?
So in T3, T4 and N1 disease, if the patient got, I prefer to give an adjuvant therapy, sir.
What adjuvant therapy?
So according to NCCN, we the adjuvant, neoadjuvant chemotherapy has given previously, sir.
Not audible. What?
So according to NCCN, if you start the patient on neoadjuvant chemoradiotherapy and in adenocarcinoma staging, so if the patient
You're not audible, yes. Not audible.
Not audible. Just tell us what will you, don't give more information. Just tell us what will you do. You have neoadjuvant chemoradiation. After surgery, your final diagnosis is YPT3, T4, T4, N1 disease. What will you prefer? How many cases have you seen and how many cases? What will you prefer? First tell us.
Say R0 resection, we can go for a surveillance.
So regardless of what you're basing all your practice on the cross trial, right? So the cross trial never had any adjuvant treatment built into it. So you stick to what the trial protocol was. So yes, unless there is an R+ resection, there is no role for adjuvant treatment in the kind of situation that you have described.
That's what, how many, like you have seen so many cases. How many cases you have seen where we give adjuvant treatment based on neoadjuvant CTRT and R0 resection? Have you ever seen any adjuvant? There is no need. Okay. Sir.
So I have no further questions. Dr. Jagjit, Dr. Altaf, please go ahead.
Satish, regarding upper GI scopy, regarding something etiology, what do you, time and again you were telling about tobacco and smoking. Why you insist so much on tobacco and smoking, how it is related to esophageal cancer?
So, but smoking and tobacco increases the risk of both the squamous cell as well as adenocarcinoma esophagus, sir.
Tobacco and smoking increases the chance of both squamous. And what about alcohol?
Yes, alcohol increases both, but more towards the squamous cell carcinoma, sir.
And quitting? What is the impact of quitting tobacco smoking? And alcohol, like quitting alcohol. What is the effect on cancer? SCC and adenocarcinoma.
So quitting smoking decreases the risk of squamous cells, sir, but it doesn't directly correlate with adenocarcinoma, sir, as it correlates with decreasing incidence of squamous cell carcinoma.
Why? Why quitting alcohol does not, or quitting tobacco does not affect adenocarcinoma? The progression Adenocarcinoma.
Yes, sir.
What it suggests?
So it suggests as a kind of a failed cancerous effect on the.
No. Like quitting tobacco decreases the chances of progression of squamous cell carcinoma, but it doesn't happen with adenocarcinoma. So what it suggests?
So like in a squamous cell carcinoma, we can halt the progression, sir, but that doesn't happen in adenocarcinoma, sir, by quitting smoking.
By quitting smoking, there is no effect on adenocarcinoma. It doesn't halt the progression of adenocarcinoma, suggesting that this is a primary initiating event in the carcinogens. Like tobacco is a initial carcinogenesis in the event of adenocarcinoma. So even after quitting, it does not affect the progression of adenocarcinoma. The progression of adenocarcinoma goes on. What are the infective etiology you suspect in esophageal cancer?
So we can have a H. pylori infection and human papilloma and HIV infections.
Okay.
One more, Satish. When you come to our state, that is Karnataka state, especially people from North Karnataka have higher incidence of C. esophagus. The incidence of increased C. esophagus in North Karnataka people is mainly because of they have a food called jowar roti, which has been prepared and which has been packed on a cloth, in a muslin cloth, wet cloth, and it is be kept. By storage of that, there is a fungus growth. They have found it that is one of the reasons why there is increased incidence of C. esophagus in North Karnataka.
Yes. Okay, sir.
Satish, how will you improve the targeted biopsies in upper GI when you do upper GI scopy and you take biopsies? So to enhance the targeted biopsy approach, what other modalities you have? Yeah, what additional modalities do you have?
So apart from white light microscopy, we have a newer model for chromo endoscopy and narrowband imaging techniques, which increases the yield of biopsies.
What is the surveillance protocol for this patient after the patient has like taken all the treatment has been done? So what is the surveillance protocol for this patient? How often will you call the patient? What investigations will you prefer? How often will you prefer?
I like to follow up this patient every 3 to 6 months in the first 2 years, and every 6 to 12 months in the next 2 years, and annually after 5 years.
So how will you like whether any investigations will you prefer to do within this 3 months, after every 3 months in the first 2 years?
Yes, I would like to do an
What
upper
are the
G.
preferred investigations?
So apart from
Preferred investigations. Only what?
Upper G endoscopy, sir.
Every 3 monthly you will go for upper GI endoscopy.
No, so like every 3 to 6 months we can go for imaging, sir. Like CCT.
Audible. Not audible. Can you repeat that, please?
Am I audible right now, sir?
Yeah. Please. Can you tell me?
Yes, sir. Sir, like this patient has got an esophagectomy. Like, so I like to go for an upper GI endoscopy every 6 months in the first 2 years, and after 2 years, the risk of local recurrence is quite low, sir. So,
rather than what additional investigations will you prefer? Will you prefer imaging, and how often will you do imaging?
Yeah, because it is an adenocarcinoma. What other things you'll keep in your mind?
so I can also do an CCT imaging for this patient, sir.
Every 3 months?
No, sir, like every 6
Then
months.
what do you do for every 3 months? What exactly you do to see any other visible metastasis?
Apart from history and clinical examination,
Sir has given you a hint that it's a adenocarcinoma. Every 3 monthly, what will you do?
What prefer? Very commonly used.
Used.
Commonly used. Ultrasound abdomen.
It's a frequently used.
Yes, sir.
Suppose the patient presents with like esophageal, all features suggestive of esophageal stricture. So like anastomotic stricture, what will you do?
So like in a patient of anastomotic stricture, I'll do an endoscopy to know what is the severity of stricture, sir. And I'll give an options of endoscopic dilatation with the risk explaining the risk of perforation, all those stuff, sir. And we have also have an option of stenting, sir. And
okay,
yes.
what what are the options available for you in a patients who presented with dysphagia in a palliative setting?
So dysphagia in a palliative setting, multiple of I'll go for an endoscopic dilatation or stent, or we can go for an EBRT as well, sir.
Stent, how will, like, what stent will you prefer?
So based on yes, sir.
Do you what kind of stent do you have in your mind for these such patients?
In a palliative patient, I'll prefer for an plastic stent, like in the metallic stent, because
no, there is something called as covered stents and uncovered stents. Which is the one you prefer in a palliative setup?
I'm sorry, sir. I don't know.
Generally,
Sorry to intervene, sir. If we can conclude the case discussion, I think we'll proceed to Dr. Pramesh's talk. Is that okay, sir?
Please go ahead. Please go ahead. Please go ahead. Please go ahead.
I request Altaf sir and Jagdeep sir to please stay till the end, because we'll have a Q&A session for the examiners also. I thank Dr. Satish for presenting the case, and he had his whole building got a Wi-Fi problem, and at the last minute we had a mock and everything was fine. So he was tense throughout, but thank you for persisting, Satish.
Thank you, sir.
I request Pramesh sir and then Altaf sir and Jagdeep sir to please give their comments for Dr. Satish, and then we'll proceed.
Yeah, it was an excellent presentation, Satish. Good. We have covered up everything.
Thank you, sir.
Thank you very much, Satish. We did realize the challenges of the bandwidth that you had, but really good presentation, and you pushed us to ask more and more difficult questions, which is the reason it went to the level it did. So excellent job.
Thank you so much.
Before we proceed to Dr. Pramesh's talk, I think Dr. Anup sir and Sharad Desai sir would like to give a small announcement regarding the NatCon.
During the corona pandemic, we have been trying to promote academics through virtual conferences.
Hello everybody. On behalf of the organizing committee of NatCon ISO 2021, I welcome you all to this virtual conference, which is going to be held on 23rd and 24th of October, and the weekend after, which is 30th and 31st of October. It's going to be a virtual conference where many national and international eminent faculties will be taking part. It will be a comprehensive conference, and we'll be discussing about cutting-edge technology along with many common surgical oncology problems. So it's going to be compelling to all of you. Please share this information with your postgraduates and the colleagues so that we have full participation from all of you. I know we have many problems during this pandemic, but please be safe and log in from the safety of your town. And we should have a very wonderful conference this time. Thank you.
I just would like to make a small announcement. So for all the people who register soon as IASO members, the NatCon organizing committee is going to give registration free for the NatCon 2021. So please do become members as soon as possible, and you will also be able to send in your papers and posters for the award sessions. Welcome to IASO.
Thank you, Sharad sir. We now request Dr. C.S. Pramesh sir to kindly deliver his expert talk. Sir, you have our full attention, sir.
Yeah, thank you, Srijan, and thank you to the IASO. Just to reiterate what Sharad just mentioned, the IASO is one of the best organizations that you have for surgical oncology, and if you are in a career of surgical oncology, this is a not to be missed association to be a member of. So, especially with this year being the annual conference being part of the package of the IASO membership, please take advantage of that. That's the only message I want to give. So I do realize that we are almost 15 minutes delayed for this presentation. So the good news for many of you are appearing for your exams. You can quit after the first 3 slides. That's all that you require for your exams, and you can happily leave. But for those who are more interested in the nuances of esophageal cancer, please hold on for the rest of the presentation as well. So this is what I'm going to cover. The first couple of slides will be the management algorithm, and which, as I mentioned, are probably the only 2 important slides that you need to pass an exam. I'll also go into the details of whether histology matters, whether it's squamous or adeno really matters. Some of the surgical issues which we discussed during the case presentation as well, the approach as well as the extent of lymphadenectomy, the role of multimodality treatment, some of the ongoing and future research, and this is only if you are interested in getting a gold medal in your exam that you need to be part of this, and I'll summarize at the end. So these are drawn from the National Cancer Grid guidelines for management of esophageal cancer. So anyone with dysphagia, Satish got it bang on when he said that barium swallow is redundant and everyone requires an upper GI endoscopy with multiple biopsies. The optimum number of biopsies is 6 to 8, wherein the false negative rate is extremely low. And once it is proven to be malignant, you start off with a CCT of the lower neck, thorax, and the upper abdomen. If it is a G junction tumor, you go ahead with the pelvis also. And in case it's an upper or a middle third or a history of change of voice, you get a bronchoscopy done and nutritional support. The optional procedures are an endoscopic ultrasound. We don't recommend this for all cases. This specifically indicated in patients with borderline operable disease after neoadjuvant treatment or in very early disease to actually confirm that it is a T1, T2 or an N0 disease. And a PET CT is important, though we put it as optional in the NCG guidelines. This was primarily because of resource constraints. If you have the resources, a PET CT scan upstages disease in close to 20% of patients with esophageal cancer. Once you've done these investigations, you divide these into 3 big buckets. The early localized, which is the T1, T2, N0. And if you are deciding that this is early localized, you need confirmation with an EUS. And on the EUS, if you find very early disease, which is practically a case report level finding in India, which means a T1, SM1, ESD or an EMR are options which are available, which provided you have the expertise. The vast majority, more than 99% of our patients don't fit into this criteria. And if they are continuing to be T1, T2, N0, upfront surgery is justified. And practically, there's no difference between doing a transthoracic and a transhiatal esophagectomy. After the surgery, if it's an R0 resection, there is no role for adjuvant treatment. If you've misstaged this patient preoperatively, and it turns out to be an R+ resection or with positive margins, postoperative radiation may be indicated. In the same situation, if you have a patient who's unfit for surgery or refuses surgery for some reason, radical radiation with chemotherapy is a reasonable option to refer. The vast majority of our patients fall into this category of T3, T4, or N+ disease. And here you differentiate between a squamous and an adeno. In case it's a squamous, a neoadjuvant chemoradiation, either a cross or an NCCN protocol, or neoadjuvant chemotherapy with a platinum 5FU regime or a Paclitaxel platinum regime is preferred. If it is an adenocarcinoma, you have options of perioperative chemotherapy with most preferable is FLOT. The other options are ECF, EOX, or we put neoadjuvant chemoradiation as the second option here. These are reversed between squamous and adeno. Following the neoadjuvant treatment, you reevaluate with a PET CT or a CECT thorax. There is some data to suggest that doing a PET CT helps. There is a very small fraction of patients who actually progress, which you don't pick up on a CCT. But if resource constrained, a CECT thorax is a reasonable post neoadjuvant treatment investigation to do. On post-imaging, post-neoadjuvant treatment imaging, if it's a resectable disease, we go ahead with surgery. If it's unresectable, we go ahead with chemoradiation or radiation or palliative procedures. In case it's a metastatic disease on any of these investigations, regardless of what T and M, the options are palliative radiation, either external beam radiation or external beam combined with ILRT or stenting, because this offers by far the best options of palliation. All other supportive medication is probably given. If it is an adenocarcinoma, there is a role for some of these MABs, including trastuzumab and more recently ramucirumab. And if in a squamous cell cancer, if symptomatic and radiation is not feasible, for example, with a tracheoesophageal fistula, palliative chemotherapy can be offered. So all of these recommendations have now changed with the recent ASCO paper, which showed that pembrolizumab and nivolumab might have action in metastatic disease. But given the fact that these are extremely expensive medications to give, the role in India would be fairly limited. So the first question that I promised to address was, does histology matter between squamous and adeno? So if you look at the epidemiology in the West, you had an exponential increase in the number of adenocarcinomas and a corresponding decrease in the squamous cell carcinomas. With the East, there has been a more steady decline or increase. The very small increase in the adenocarcinomas, practically no difference in the squamous cell cancers. And so this seems to be a purely Western phenomenon that we are seeing. When it comes to the etiology, we see from this that the etiological factors, with very few exceptions, are completely different between squamous cell cancers and adenocarcinomas. There's a nice study from the Veterans Affairs group in the US, which shows that prognostically, these are very different diseases. Adenocarcinomas at presentation are more likely to be metastatic. But if they're non-metastatic, survival for adenocarcinoma is superior to those with squamous cell cancers. And in patients with metastatic disease, there's virtually no difference in survival between squamous and adenocarcinomas. Strangely, perioperative outcomes are also very different between squamous and adenos, and we seem to have got the bad part of this dichotomy. Most complications, including mortality, respiratory complications, cardiovascular complications, arrhythmias, anastomotic leaks, all of them seem to be more common with a squamous cell cancer. And that's probably based on the location of the tumor rather than the histology. And again, survival in patients who are operated for squamous cell cancer is inferior to those operated for adenocarcinomas. So while squamous and adenocarcinomas have different etiology, different presentation, and different prognosis, we do realize that research and management guidelines have, however, remained the same. So this is one of the first myths that I want to break, that squamous and adenocarcinomas of the esophagus are two different diseases, and we should stop treating them as one disease. We'll move on to the surgical issues, which are central to this group, which I'll focus on two major issues, which are the approach of surgery and the extent of lymphadenectomy. Many of you might have seen this meta-analysis, which is considered level 1 evidence. But if you go into the details of the meta-analysis, there were 50 trials which were included in this, but only 3 of them were randomized trials, and only 6 of them were prospective. The vast majority were retrospective studies, which, as all of you know, is very low level of evidence. And this meta-analysis went on to suggest that there was no difference in outcomes with complications when comparing a transhiatal to a transthoracic esophagectomy. The overall complications were similar. The anastomotic leaks and vocal cord paresis were similar. But when you looked at only the randomized data, which is the more reliable data, unfortunately with very few numbers, there is again no difference in the complications. So virtually what it shows is that whether you do a transhiatal or transthoracic esophagectomy, there is no difference in the complications, unlike what we believe or what we would like to believe, that transhiatal has a lower leak rate or a lower complication rate. This is a more recent meta-analysis, but unfortunately suffered from the same drawbacks as the previous meta-analysis. They included all studies, including a vast majority of retrospective studies, and I wouldn't give this much credit. Probably the best study that we have on this issue is the Dutch randomized trial, which randomized close to 220 patients to a transthoracic and a transhiatal esophagectomy. I must emphasize the fact that this was restricted to adenocarcinomas And this, in the initial report, showed a 10% difference in overall survival between a transthoracic and a transhiatal. The TTEs did better than the transhiatal, but because the study was had a very small sample size, this did not reach statistical significance. But the long-term follow-up of this study showed overall no difference in 5-year survival, practically the same, 36 versus 34%. So many people went with the message that it didn't make a difference whether you did a transhiatal or a transthoracic esophagectomy. But what the study actually showed was when you separated the esophageal, the pure esophageal cancers from the GE junction tumors, the GE junction tumors showed no difference, whereas the pure esophageal tumors showed a 14% difference in survival between a transthoracic, a 51% survival with transthoracic versus a 37% survival with a transhiatal esophagectomy. So even with adenocarcinomas, where you would expect the benefit of a transthoracic approach to be lower, you did have an advantage as long as it was restricted to esophageal cancers. So the authors concluded that they would recommend a transthoracic esophagectomy for esophageal cancers and a transhiatal esophagectomy for junctional and for cardiac cancers. So all of this was the biggest controversy till minimally invasive esophagectomy came in. And we all know the theoretical benefits of this, technological advances, less invasive, the initial fears of oncological safety were addressed. And there were several reports with surrogate oncological safety variables like lymph node yield and an R0 resection rate. And a meta-analysis of these studies, again, suffering from the same drawbacks as the TT-THE studies, a lot of retrospective studies showed that most of the studies favored a transhiatal approach, a minimally invasive approach over an open approach. But let's look at the randomized trials, and there are 3 of them currently. The first one published was the TIME trial, which looked at primary outcomes of pulmonary infection. And what this showed was that if you did an open esophagectomy, you had 3 times as many pulmonary infections as minimally invasive esophagectomy. And the primary endpoint was met, that the minimally invasive approach was superior to the open approach. As expected, the disease-free survival and the overall survival were not different between the 2 groups. This is what we expect. The second trial which came out was the MIRO trial, which looked at a hybrid minimally invasive esophagectomy for cancer. Again, met the primary endpoint that major complications were 50% with the total trial population, whereas it was 36% with a minimal invasive and 64% with an open esophagectomy. So clearly superior outcomes with a minimal invasive esophagectomy. The surprising part about the MIRO trial was that this also showed a non-significant improvement in overall survival with a minimally invasive esophagectomy. So I find this difficult to explain, but nevertheless, this was what the study showed. This is the disease-free survival graph, and this is the overall survival graph, narrowly missing statistical significance, but the graphs seem fairly widespread. But what happens in the real world? We all know that results in randomized trials are not replicated in the real world. So this is a very nice study which was done from Japan. And if you were to look at real world evidence, I would strongly suggest that you go to Japan, because you have the least variability between the quality of surgery that's performed between various centers and between various surgeons. And what this showed was that the difference in outcomes between an open and a minimal invasive esophagectomy were restricted to just 2 outcomes, which were blood loss and operative time, and also with atelectasis and prolonged ventilation, which most people would not consider as a strong enough endpoint. And even if you look at those, the differences are marginal, 5.1% versus 3.6%, 10.9% versus 8.9%. So really not a dramatic difference the way you saw with the randomized trials. And even with other aspects of care, you notice that the differences were not very different. So I'll just point your attention to this gastric tube necrosis. Very small difference, but 0.4% in the open and 0.8% in the MIA group. Not statistically significant, but I just want you to pay attention to this. And based on this study, the Japanese esophageal surgery group launched a randomized trial which aims at recruiting 300 patients. This is a non-inferiority trial with an endpoint of overall survival. And I think this is going to be probably the pivotal trial which will push minimal invasive esophageal one way or the other. Similar results from the Netherlands, where they did a propensity score matched analysis of open versus minimal invasive surgery. And this was not, again, randomized. This was the community practice that was seen. And virtually no difference in outcomes between the two groups, except, I'll point you again to this, gastric conduit necrosis, 0.2% versus 3.2% in the MIE group. So this doesn't seem to be just a chance finding. For whatever reason, though we are not able to explain this, there seems to be a slightly higher possibility of gastric conduit necrosis. This might be related to energy devices. This might be related to something unrelated. This might be related to handling, whatever it might be. There does seem to be a slight handling issue with the gastric tube necrosis, and virtually all the other endpoints were no different between the two groups. So as far as this particular controversy is concerned, minimal invasive vasectomy probably is the ideal approach, but and has morbidity reduction with equivalent oncological outcomes. But however, this needs to be done in experienced centers like what was done in the randomized trials. And probably when it's extrapolated to community practice, the benefit is no longer seen. I'll move on to the role of lymphadenectomy. This is a big controversy, like many other solid tumors like breast and melanomas in surgical oncology. And I'll urge each one of you who's interested in the history of esophageal surgery to go through these seminal articles by Akiyama, Surumaru, and colleagues from Japan. They've done probably the best work on the role of lymphadenectomy, where they initially showed that the propensity of squamous esophageal cancers to have cervical lymph node involvement was anywhere from 25% to 40%. And based on this, they went ahead and did the subsequent study, which again is a really nice article. It's the sheer beauty of the paper that is written here, where they meticulously mapped out every single lymph node that was positive. And they showed that as you go lower down the esophagus, the chances of metastasis in the supracarinal and the cervical lymph nodal basins were exponentially high. And even with lower esophageal cancer, what you see is a 27.2% possibility of cervical lymph nodal metastasis. And they clearly showed that in this retrospective study, there was close to a 12% difference in overall survival if you did a 3-field lymphadenectomy. But this is a retrospective study, and all the drawbacks of a retrospective study do stay with this. Based on this, in 1994, the ISD annual conference suggested that there were 3 issues to be addressed: the morbidity and the mortality, the local regional control, as well as the survival. There were 2 randomized studies, both of which were very small studies, both from Japan, which seemed to indicate, one, which was a positive study, the Kato study, which showed a 15% difference, and the second, which was by statistical terms a negative study, but again an 18% difference, which suggested a 3-field lymphadenectomy did superior to a 2-field lymphadenectomy. Probably the largest study that's ever been done on this issue comes from this nationwide study, again a retrospective study from Japan, which evaluated 1,800 3-field dissections from 35 institutions, 2,800 2-field dissections from 61 institutions, and they looked at operative mortality, no different, nerve palsy, higher in the 3-field group, lymph node metastasis, higher in the 3-field group, but still showed a 7% improvement in survival with the 3-field lymphadenectomy. They showed that the operative, so this is a repeat of that slide. So we have just recently concluded at the Tata Memorial the largest randomized trial on 2-field versus 3-field. We've randomized 700 patients, half of whom got 2-field lymphadenectomy and the other half got 3-field lymphadenectomy with the primary endpoint of overall survival, which we hope will answer this question conclusively. We're just waiting for the survival data to mature before we publish. We move to this next question of multimodality treatment. This controversy arose from the intergroup trial, which was a neoadjuvant chemo versus surgery alone trial, showed no difference. But the MRC trial showed a statistically significant survival difference with neoadjuvant chemotherapy. With the neoadjuvant chemoradiation, the initial trial, the Australian trial showed no difference, whereas the cross trial showed a significant difference in outcomes. And as you do when you get controversial treatment options like this, you decide to do a meta-analysis. There have been 2 well-conducted meta-analyses in 2007 and 11, which clearly showed that when you gave neoadjuvant chemotherapy, it improved outcomes over surgery alone. when you gave neoadjuvant chemoradiotherapy, it improved outcomes over surgery alone. However, what the meta-analysis did not show as clearly was the mortality differences. When it came to neoadjuvant chemoradiation, the mortality differences favored surgery alone, which meant that mortality, perioperative mortality was higher if you gave neoadjuvant chemoradiation, whereas if you gave neoadjuvant chemo alone, there was no difference in outcomes. And the final meta-analysis actually showed that the postoperative mortality was doubled with neoadjuvant chemoradiation compared to surgery, whereas it was identical when neoadjuvant chemo was compared to surgery alone. We've had several subsequent trials which have looked at varying options of neoadjuvant treatment. The MRC did a different trial looking at cisplatin 5-FU versus 4 cycles of ECX. And while toxicity was much higher with ECX, the 3-year survival was very similar, so which kept cisplatin 5-FU as the standard of care. Something that's revolutionized treatment recently has been the FLOT4 trial, which compared the FLOT regime with the MAGIC trial. And it clearly showed that FLOT had better progression-free survival, 30 versus 18 months, and overall survival, 50 versus 35 months when it came to outcomes after treatment. This is a more recent trial, the NEO-REST trial. This was a phase 2 trial, which looked at complete response rates as the primary outcome. It was positive, 28% with neoadjuvant chemoradiation compared with 9% with neoadjuvant chemotherapy. R0 resections were superior with chemoradiation compared with chemotherapy. But what the survival data showed was very different, that there was practically no difference whether you gave neoadjuvant chemotherapy or you gave neoadjuvant chemoradiation in this group of patients. And this was a combination of adenos and squamous. And the next slide will show you why I emphasized earlier on that we need to separate the two. When it came to adenocarcinomas, there was an actual detriment to giving neoadjuvant chemoradiation as compared to chemotherapy alone. And this was reversed in the squamous cell cancers. Both of these were statistically non-significant, but the squamous cell cancers showed a survival advantage with neoadjuvant chemoradiation. There is another trial which has come on recently, which is the NEO-AEGIS, which looked at over 360 patients in an interim analysis. And what this compared was the cross protocol to the MAGIC or FLOT. They started with the MAGIC, and when the FLOT showed superiority, they converted to FLOT. And again showed virtually no difference in outcomes, whether you gave neoadjuvant chemotherapy or you gave neoadjuvant chemoradiation. There are currently 2 other ongoing trials, the ISOPEC, which directly compares cross with FLOT, and the Top Gear, which based in Australia, which looks at perioperative ECF versus perioperative ECF with neoadjuvant chemoradiation, and the survival results are awaited. So the final conclusion with neoadjuvant therapy is that in US and Europe, neoadjuvant chemoradiation is used. There is this option of MAGIC or FLOT available, whereas in the East, neoadjuvant chemo is the preferred option. There has been compelling evidence from the cross trial with neoadjuvant chemoradiation associated with slightly higher perioperative morbidity and mortality, especially in non-experienced centers. And increasingly, there is evidence supporting checkpoint inhibitors and immunotherapy, and this is work in progress. I'll go towards the final part of the entire talk by ongoing and future studies. Probably the most awaited study is this study from Japan, the JCOG 1109 trial, which is randomizing patients to a 2-drug chemotherapy regime to a 3-drug chemotherapy regime versus chemoradiation prior to surgery. And I think this will answer a lot of the questions when it comes to locally advanced squamous esophageal cancer. Recruitment is complete and we are awaiting final results. The other trial that I want to emphasize is the AD-ASPIRIN trial, which the National Cancer Grid developed in coordination with the Medical Research Council in the UK. This is a large double-blind placebo-controlled trial randomizing patients. And this is actually a 4-cancer type trial: breast, colorectal, gastroesophageal, and prostate, which randomizes patients who have completed radical treatment for esophageal cancer to either 100 milligram of aspirin, 300 milligram of aspirin, or placebo for 5 years post-operatively. And we are in the process of recruiting for this study. Many of the individuals who are part of the study are as participants in the study as well. Again, an important trial, the SANO trial from Netherlands. SANO stands for Surgery as Needed for Esophageal Cancer. This draws from the results of the cross trial, where 49% of squamous esophageal cancers had a complete response, The question that the SANO trial will answer is, in complete responders after neoadjuvant chemoradiation, is surgery really required? This is a non-inferiority step wedge cluster randomized trial. It's a pretty complicated study design, but what they're looking at is whether in patients who have had a complete response after neoadjuvant chemoradiation, whether active surveillance might be as good as esophagectomy. There's this recently started NEEDS trial, again, which starts from the Swedish group, which is looking at a phase 3 non-inferiority randomized trial, primarily based at squamous cell cancers, different from the SANO trial in the fact that this gives definitive doses of radiation along with chemotherapy and combines and compares this to the neoadjuvant chemoradiation as per the cross protocol followed by surgery. This is a multicentric multinational study. We are in the process of submitting ethics approval for this. And if any of your centers are interested in participating in this study, you can contact me and I'll put you in touch with the primary investigators. To end with some of the unresolved issues in esophageal cancer, we still don't have answers to whether the ideal treatment that is neoadjuvant is neoadjuvant chemoradiation or chemotherapy. Is definitive chemoradiation an alternative to surgery in squamous cell cancers? I doubt that it's going to be an alternative in adenocarcinomas. Will neoadjuvant immunotherapy completely change the paradigm? Is radical lymphadenectomy likely to improve survival outcomes? And our trial, along with a concurrent Chinese trial, is likely to answer this question. And finally, is there a role for postoperative treatment, especially in R+ high-risk patients? Will radiotherapy make a difference, and the ADASPIN trial as well? To summarize, the evidence base that we have for management of esophageal cancer today has improved substantially from what it was 2 decades back. What was eminence-based and vehemence-based 2 decades back has now turned out to be strongly evidence-based, and I'm happy that the esophageal community has worked towards this. We realize that multimodality treatment is key. Minimal invasive esophagectomy and a transthoracic approach are probably superior, especially in squamous cell cancers. The level of lymphadenectomy does matter. However, several unanswered questions remain, and I'm happy to take any questions if you have any. I apologize for the fact that we've run 10 minutes over, but we did start 10 minutes late as well.
Thank you so much, Pramesh sir, for that excellent talk. And I think you've already covered so many of our questions, which are for the Q&A section. But for the audience, I think we'll go through them for some take-home messages as well. I invite Dr. Jagjit Pandey and Dr. Altaf Syed sir also. So I've clubbed certain questions together as they were related. These come from both the audience here as well as on YouTube. Our first question, I would be addressing these questions to certain examiners. However, the other examiners are equally welcome to chip in. So you talked about the 2-field and 3-field.
Before you start, would you mind asking the first couple of questions to the other examiners? I need to give my voice a break.
Sure, totally, sir. So our first question is, what are the indications for extended 2-field and 3-field lymph node dissections today in esophageal cancers? And related to the same question, are the recurrent laryngeal nodes, are they potential sentinel nodes for esophageal cancers? Dr. Jagjit sir and Altaf sir. Yeah, Dr. Jagjit.
Srijan, what's the question? Like, I can't see.
You're not able to see, sir. So the question is, real world, what is your indication for doing an extended 2-field versus a 3-field lymph node dissection for esophageal cancers? And would you consider recurrent laryngeal nodes as potential sentinel nodes for the esophageal cancer?
Yeah, for this, already sir has given the complete talk on 2-field as well as 3-field lymph node dissection. Now this RLN nodes, yeah, definitely it is considered as what we see, it's a potential sentinel nodes. So for this, definitely the 3-field lymph node dissection is certain because of the higher morbidity associated with this. So majority of the centers, they confined it to 2-field, but the 3-field lymph node dissection has certain advantages over it. So considering the morbidity, we confined ourselves to 2-field.
I would like to add one more thing in this is when you take 2-field and 3-field, the morbidity is more in 3-field, and the hospital stay is also more in 3-field lymphadenectomy compared to that of 2-field lymphadenectomy.
So which patients would you choose for 3-field versus extended 2-field, sir?
See, most of the patients who come to our institute or their general condition is pretty bad. They are most of them are not even fit for THE and TTE also. We come across such kind of patients in our institute, and putting into this one, the hospital stay and the cost, everything increases. We cannot even the morbidity increases more. We try to restrict ourselves only to 2-field.
Thank you. Ramesh sir, can we have you back? Yeah.
Yeah, sure, of course.
Thank you, sir.
Yeah, I think what both of them said is extremely important. Fitness is a very key consideration. The morbidity of a 3-field lymphadenectomy is not a small, so you need to choose your patients carefully. I think there is no controversy about the fact that if you have morphologically or metabolically active nodes in the supracarinal or the cervical region, you have to do a 3-field lymphadenectomy if you are offering surgery. But the evidence is less clear when you don't have obviously metastatic nodes in the supracarinal and the cervical region. So I would be very, very careful about choosing these patients. If they are fit and they have a high propensity to have occult metastasis in the supracarinal or cervical, I would offer a 3-field, but otherwise just a 2-field should be adequate.
Can I ask one question to Dr. Parmesh, please?
Sure, sir.
Yes, sir. How often? What is the hospital stay in your institute when you offer a 3-field lymphadenectomy?
So, as I mentioned, we are very selective about whom we offer, except for patients who went on to that randomized trial. But whatever we've seen and compared, I wish I'd got the data. I've got the slides here, but I think in the interest of time, I will not show them. But the hospital stay and the mortality is not different. Where it makes a difference is the morbidity. The pulmonary complications are certainly higher, and the recurrent laryngeal nerve paresis rates are definitely higher with the 3-field, because obviously you're handling the nerve in the supracarinal and the cervical region, and you're more likely to hit them. But when it came to outcomes like esophageal anastomotic leak or gastric tube necrosis, there was no difference, which are probably the most dreaded complications you have. Pulmonary complications are generally salvageable, and surprisingly, even the tracheostomy rates and the need for bronchoscopies were actually no different between the two groups. But I must say that these have been in carefully selected patients who are fit to undergo a 3-field lymphadenectomy.
Thank you, sir. Next question to Altaf sir. So how does a esophagogastric leak management happen in your institute, and how do you manage diet during that leak period? I've also added a second question to this. How different is it when you have a mediastinal leak versus a cervical leak during the management?
See, generally esophageal leak in our institute, especially neck leaks, we manage conservatively, and all the patients undergo feeding dyspnostomy. The moment we see the patient with esophageal anastomotic leak, we stop completely, nil by mouth, and straight away increase the input through the feeding tube. We go in for high protein feeding dyspnostomy. We give as much as possible to the neck. If it is required to be explored, we will explore. If it is not required, we can manage conservatively. We manage it by conservative line of treatment. And mediastinal leak in our institute, we have seen very less.
Any inputs from Dr. Jagjeet and Dr. Parmesh, sir?
Yeah, as rightly said, Dr. Altaf, majority of the time the cervical leak don't require any intervention. and it's only the feed which we have to take care. The nutrition part we have to take care. So from the feeding jejunostomy side, we can take care of it considering high energy, high protein diet. What Pramesh sir has during the course of our discussion, he has very well told the management protocol for the mediastinal leak. So considering if the patient has significant mediastinal leak leading to symptoms, then only we have to coordinate with our intervention radiologist to put a pigtail to take care of this mediastinal leak.
So the experience that we've had is slightly different, and that probably deals with the fact that we do a linear stapled anastomosis. The advantage of a linear stapled anastomosis in the neck is that the anastomosis is very wide, very voluminous, and it practically, we've not dilated a stricture in the last 10 years. But the problem about a linear stapled anastomosis in the neck is that the esophageal length is longer, and most of our so-called neck anastomosis actually end up leaking into the mediastinum. But we have a phenomenal set of intervention radiologists who are able to pigtail practically everything in the mediastinum, and we've salvaged most of them without having to re-explore them. So slightly different experience, but I guess this is to do with the technique of anastomosis as well.
Thank you, sir. Our third question to Dr. Jagjit Pandey. What are your contemporary indications for a colonic conduit, sir? And the second rider to the same question, what is your option of choice for a Sievers type 3?
See, my personal experience with colonic conduit, I haven't done yet in this colonic conduit. So preferably I prefer Ramesh sir to because even I'm not focused on this colonic conduit. So Ramesh sir, I'll pass on this thing to you, sir, regarding your experience for colonic conduit.
So though our unit does a lot of, a fair number of colonic conduits, these are predominantly reserved for patients who leaked and had a disconnection, and you want to do a reconnection of the esophagus with the stomach tube. We rarely do a primary colonic transposition because the leak rates are higher, the complication rates are much higher. But having said that, especially for very early cancers, this is an option. But if it comes to a Sievers type 3, I would prefer to do a left thoracoabdominal with an anastomosis in the lower mediastinum rather than offer a colonic conduit, because you still are able to give a good margin up to 5 centimeters with this approach. And personally, I think the stomach is a far more reliable conduit than a colon. But in the occasion that's required, we don't hesitate to replace with the colon as well.
Our next question to Dr. Pramesh sir only. Sir, how we are awaiting the results of the RCT regarding definitive CRT versus neoadjuvant chemo-RT followed by surgery. But how do we counsel patients regarding both the modalities today upfront before starting any treatment?
So right now, I'm very comfortable counseling patients that neoadjuvant chemoradiation or neoadjuvant chemotherapy followed by surgery is probably the most established option. Not because I'm a surgeon, because we don't have data to support definitive CTRT. There's a very small study from Germany and France which showed this, but those were never powered to show a non-inferiority. So currently, the strongest data that we have is the neoadjuvant treatment followed by surgery. And I must share some data from the ADASPRINT trial, which will probably surprise many of the proponents of definitive CTRT, though I'm one of the co-investigators in the definitive CTRT versus the neoadjuvant treatment versus surgery trial. The results with neoadjuvant treatment with surgery in esophageal cancer today is very different from what it was 20 years back. So I'm extremely comfortable in not offering definitive chemoradiation for patients unless they are unfit or if they refuse surgery for some reason.
Now, your ongoing trial, what exactly does it indicate, sir?
No, we've not. So the study has just started. It's a multinational study based out of Sweden, India, and Austria, which is looking at a definitive chemoradiation, full dose radiation with chemotherapy versus neoadjuvant chemotherapy chemoradiation by the cross protocol followed by surgery. And we're looking at non-inferiority of overall survival as an outcome. So we've just started randomizing patients. You can't expect results before another 7 or 8 years.
Sir, more thing. When we counsel the patient regarding only definitive CRT, so can't we give the tell the patient that until unless we don't do esophagectomy, we cannot comment upon the PCR what we achieved pathological complete response until unless we don't do esophagectomy. So isn't it because majority cross trial has also given the data of only 29% neoadjuvant CTRT. So
yeah, so that's absolutely right. But when you look at the squamous cell cancer subgroup in the cross trial, the complete response rate was 49%. So I don't deny that there is a strong case where you need to study this question, whether definitive chemoradiation could be as equivalent and with salvage surgery being an option. But the point is we don't have the data today. And if we were to counsel a patient today, I'm very comfortable saying that we have strong data to support neoadjuvant chemoradiation followed by surgery and not very strong data to support definitive chemoradiation.
Yes, sir. Our next question also is regarding the definitive chemoradiation. When should we consider investigating the patient at all to think of salvaging? Dr. Altaf, sir.
Can you again tell the question, please?
Sir, if we have given definitive chemoradiation, after what timeline or symptom signs should we consider investigating this patient and then considering for a salvage surgery, sir?
Generally, what we do is in our institute, we give a gap of 3 weeks. We subject the patient again to an endoscopy, see if there is any changes in the endoscopy. And we make it a plan that till 6 weeks, we keep it on surveillance of this particular patient. And later on, we tell the patient if there is any, when he supports or tells us any history of any dysphagia or any history of his old symptoms and signs, then we thoroughly investigate this patient to go for a further treatment.
Right, sir. Any inputs from Dr. Jagdeep and Dr. Pramesh, sir? So,
generally, I'm not a proponent of, as Pramesh sir has also pointed out, that definitive CRT, even we consider definitive CRT only in those patients who are not fit for surgery, not willing for surgery. So until unless these are the only, at present, we give an options only to these patients. When these patients after definitive CRT, if they are non-responders, so after we wait for another 3 to 4 weeks, and then if the patient has no response, and if somehow the patient has come into those pictures, even after counseling, the patients start thinking on lines of definitive treatment in terms of surgery, then only after 3 to 4 weeks, we start investigating the patients for salvage surgery.
So our approach would be that if someone opts for definitive chemoradiation, it's a conscious choice that they want to avoid surgery. And we would investigate only if they become symptomatic again. So we would stop at that.
For a transthoracic esophagectomy, whether to do a staging laparoscopy in the abdomen and see the abdomen before initiating the thoracic dissection. Dr. Jagdeep.
Yeah, for Sievert's type 3, and preferably if we extend more for 2, we do staging laparoscopy before initiating TT. So our preference is mostly towards Sievert's 3, G junction tumors, for staging laparoscopy before initiating TT.
Altaf sir and Pramesh sir.
Same. I mean, generally, if it is lower esophageal growth, that is G junction growth, then only we prefer to go in for staging laparoscopy.
So I would just add that this would probably need to be done before starting neoadjuvant treatment, because what you're actually looking for is undiagnosed metastatic or peritoneal disease or mental metastasis, yes, which if you've already given neoadjuvant treatment, you are likely to miss out. So if at all you want to do a staging laparoscopy, and we do that in type 3, type 2 and type 3 CVERTs, we would do it pre-neoadjuvant treatment.
Right. Our last question to Pramesh sir. Is reassessment staging post-chemoradiation an absolute requirement if symptom relief is excellent? And the other two questions are also related to this, whether the margins will be based on upfront assessment or the post-CRT findings. And complete clinical response, I think you've already answered in your talk.
Right. So these are excellent questions. The point is that for the first part of the question, the first of the three questions, we don't have data. But what we know is that in general, if there is symptom relief, then the patients have responded. But I think in today's practice, to not restage with a CT thorax at least prior to surgery would not be acceptable. But I do take the point of whoever has asked this question, that if the clinical response has been good in a patient with resectable disease, then it's highly likely that even without imaging, you can go ahead. But it's probably tradition and routine practice that pushes us towards that. And I would be personally uncomfortable not documenting this with a response CECT thorax. I wouldn't say a PET CT, but a CECT thorax and upper abdomen before surgery. Coming to the margins, whether they are based on upfront or post-chemoradiation, I don't think any of us know the answer to this. There are no studies or no data to support either of this. But fortunately, in the esophagus, we are fortunate because unlike other parts of the other solid tumors, you anyway need to do a total esophagectomy. And it's rarely that you would change the extent of your gastric tube based on what the current situation is. So I would go based on the pre-treatment findings rather than the post-treatment findings. And finally, with the complete response, wait and watch, I think the SANO trial will answer this question. But I find the SANO trial a little uncomfortable because what we are giving is actually a low dose radiation. 41.4 gray would not be considered curative by most radiation oncologists. So I'm fairly more comfortable doing the NEETS trial rather than SANO trial.
Can I ask the last one, please, to both Dr. Jagjit and Dr. Pramesh? So how often do you see gastric tube necrosis in your institute? Because we have not seen any gastric tube necrosis till this day.
Even I haven't seen any gastric tube necrosis till date. What I have done, I have never seen. And even in GCRI, when I was doing my MCH, I haven't seen any. So gastric tube necrosis still.
What about you, Dr. Parmesh?
I think we should probably come to both your centers and learn, because we do see gastric tube necrosis in some patients. We would like it to be a zero rate as in your centers, but we do get a couple of patients every year who do develop gastric tube necrosis. And by far, the single most important complication I would want to avoid with an esophagectomy is a gastric tube necrosis. So it's 2 out of 180, but it's still 2 patients who have a very high mortality rate. So I think if you can avoid gastric tube necrosis, you can probably handle any other complication, but gastric tube necrosis does cause a significant morbidity. But we do see 2 or 3 patients every year.
Thank you, sir. Thank you.
Thank you, all the 3 examiners from my side, for so patiently answering and actually discussing on these set questions. I invite Dr. Sharad Desai now to please give his closing comments.
Thank you, Srijan. Today was a wonderful day. I really enjoyed today's masterclass. Satish has presented the case very well. Esophageal cancer is a very common disease and it's very popular among students and even among practitioners. And he has answered most of the questions well, despite his low bandwidth, and he has done well. I wish you all the best in future, Satish. Dr. Pramesh sir has been one of our go-to man in thoracic oncology as far as IASO is concerned. But recently, due to his additional burden of his position in the Tata Memorial Hospitals and due to the volume of responsibility which he bears all the time, the IASO has been missing you, sir, for the last few years. Today, we are lucky to have you. And on the behalf of the ISO, I thank you and for participating and for bringing repute to the masterclass, despite your busy schedule, especially. Dr. Jagjit, Dr. Altaf, we have been hearing about you both, and I'm happy to meet both of you again here. And
thank you for inviting us, sir. Thank you so much for inviting us.
It's
been a pleasure actually. By knowing both Dr. Jagdish and Dr. Paramish, it was a real pleasure to know them also.
Yeah, and I hope both of you young keep on appearing in the ISO and keep communicating, keep attending our meetings more and more often, and please bring in more of your colleagues to the ISO. Finally, for our participants and ISO members, all our students, I hope you have enjoyed this session. Keep writing to us, keep giving us some feedback or on YouTube also. And we'll again meet on 26th August for our next seminar, that is on the lung cancer. And it's the same day, same time, and on the same platform. So we are going to have our NatCon again this October last week. And I remind you, please register, and you will be getting a free bonanza of becoming a free registration also, and your papers and posters of the competition and awards. Dr. Sarangi sir, thank you for organizing this meeting and putting in the hard work. Also must thank our past presidents, Dr. Chaturvedi sir, and Dr. Rajan for the continued support. From the Indo-American Center, I have already been thanking you, Srijan and Dr. Subramanian Rao. This time I just kept, I just reminded myself that I should also thank all the small staff who have been participating behind the screen, people who have been helping you for conducting this masterclass. Please, on behalf of the ISO, please thank them all. So I thank Dr. Arnab Gupta and my ISO colleagues for supporting this program. Thank you again, and stay safe. See you soon again.
Thank you, Sharkan.
Thank you.
For everybody signs off, a very quick thank you from my side. Again, a wonderful PG Masterclass. We really enjoyed. The examination went really well. The examinee did very well, and the faculties had been brilliant. So was the expert talk. We really enjoyed, and thanks to Academic Council once again. And everybody, please become members of ISO and don't miss this opportunity of attending the NatCon virtually. Enjoy the rest of the evening. Thank you very much.
Thank you.
Conclude the webinar tonight. Good night and good luck.
Sir, I am extremely thankful to Arnab sir, Sharad sir, Subha sir, and Sarangi sir for giving us an opportunity. We have started our MCH program last year only. So thanks for giving us an opportunity. Thank you, sir.
It was our honor. Thank you very much.